Morning, everyone. You guys can all take a seat. So today we have Dr. Satish Nagula, our very own. He's Associate Professor of Medicine, Associate Program Director, and Director of Endoscopic Ultrasound here at Mount Sinai. And he's going to be talking about contemporary management of acute pancreatitis.
All right, good morning. Well, as you're all hydrating with coffee, I think the ultimate oxymoron. I'd like to talk a little bit today about the contemporary management of acute pancreatitis, dispelling myths, optimizing care. It's not just all NPO and pain medications, or maybe it is, but hopefully today you'll walk away with an understanding of why we do what we do and what are the gaps in our knowledge. I do not have any disclosures. As a brief outline, what we're going to do today, we're going to talk a little bit about the definitions, some categories and outcomes, management strategies. We'll dive into a couple of special topics on gallstone pancreatitis and necrotizing pancreatitis, and then we'll come away with some final few words. It's amazing what you can find when you Google pancreatitis and comic. And so this one is you've got like a feng shui problem with your pancreas, dude. And so for definitions, some of this stuff might seem kind of basic, but it turns out there are just a lot of assumptions people have made. So sometimes it's good to review how we really approach the disease. You need to have 2 out of 3 criteria. So you have to have an elevated serum amylase or lipase, preferably lipase. It's a little bit more specific. More than 3 times the upper limit of normal. You should have what we call typical pancreatic pain. This is severe acute onset epigastric pain that's radiating to the back. Or you need to have typical imaging findings. So the key here is you need to have 2 out of 3. You do not need a CAT scan, of which the ER doesn't seem to quite understand that always. But you don't need a CAT scan to make this diagnosis. If you have a high lipase and you have a really good classic typical history, which most of our pancreatitis patients do, then you have cinched the diagnosis of pancreatitis. Now, where does imaging come in handy in the acute diagnosis? Well, if you only have one of these other 2 criteria, so if the lipase isn't quite elevated enough, or if the pain is a little bit atypical, maybe it's been smoldering for a week, maybe it's not quite epigastric, and then imaging can sort of cinch or nail that diagnosis. The degree of enzyme elevation has no correlation with severity whatsoever. I have seen patients who've had a lipase of 40,000 or 50,000, astronomically high lipase, who've been sent to a step-down unit because they were worried about how severe this pancreatitis was going to be. The degree of elevation has no bearing whatsoever. Once you cross the diagnostic threshold, that's it. You don't need to follow lipase anymore, and you certainly don't need to care about how high that number is. The other thing that is important to recognize, and is the subject of many consults we'll see in the office, is you need to watch for unrelated causes, or non-pancreatitis related causes of elevated amylase and lipase. So if you take a look at this chart here, if you have patients with an elevated pancreatic amylase and lipase, and they have no symptoms at all, and it's just a random finding, they checked that box on the lab sheet for an amylase and lipase in addition to a non-indicated tumor marker and an extra, CRP or whatever. These are sort of incidental things. Maybe it's something familial and the way that their enzyme levels are. Certain medications can cause elevated levels of lipase and amylase. If a patient has had an ERCP, that will always cause an elevated amylase and lipase for at least 24 to 48 hours. That's not pancreatitis. There are macroamylasemias that can cause elevated levels, and even just systemic diseases may cause it. If a patient has no symptoms presently, but had pancreatitis in the past, this might be related to some kind of ampullary stenosis. Maybe they have some scarring in their pancreas or their ampulla that causes them to have elevated levels of serum amylase and lipase. What we see a lot of are patients who come to the emergency room with some nausea and vomiting and some vague discomfort, and they have a mildly elevated lipase. If the upper limit of normal, let's say, is 60, their lipase is 100 or 110. Well, lipase and amylase can go up as a non-specific response to systemic illness. There's actually amylase in the bowel wall, so any irritation or dysfunction there may cause an elevated serum amylase or lipase. So again, this comes back to that criteria. Do the symptoms fit pancreatitis? Okay, vague nausea and vomiting, that's more like a gastroenteritis, and a non-specific lipase, that's not pancreatitis. And then if a patient has pancreatic type symptoms, and then they have elevated amylase and lipase, then of course you need to think about your pancreatic sources of pain, such as pancreatitis, acute or chronic, pancreatic tumors. So in terms of causes of acute pancreatitis, one could spend a whole other talk just delving into this topic alone. In the United States, about 40% or so are related to gallstones. Another 30% or so is related to alcohol use. There's about a 10% idiopathic. And then about a 20% other category. Now, that other category is rather large. There are patients with post-ERCP pancreatitis, autoimmune, drug-induced pancreatitis, certainly some of the new diabetic medications, or the immunomodulators like azathioprine. Pancreatic cancer, infrequently, but certainly can cause pancreatitis, pancreatism, elevated triglycerides, hypercalcemia, genetics, viral, postoperative, particularly after coronary artery bypass or when patients go on to cardiopulmonary bypass. Sometimes with the low perfusion states, they get almost a shock pancreatitis. And then something I should add on this slide for the next time is scorpion bites. It is real, and there are case reports out there, but I haven't seen one. So in terms of pathophysiology, mechanisms of pancreatitis, the end common state here is premature activation of those digestive enzymes. Remember, those pancreatic enzymes are stored in an inactive form within the pancreas. And when those enzymes are activated, which is usually in the small bowel when it gets to mix with food, that's when their digestive activity begins. But in certain conditions, so if there is a duct obstruction, so you transiently occlude the ampulla and you send a wave of pressure into the pancreas, that causes some alterations in blood flow, ultimately leading to acinar cell injury, causing those enzymes to activate prematurely, digesting the pancreas. Any direct toxin to the acinar cells, so alcohol is classic, drugs, certain infections like mumps, these cause direct injury to the acinar cells, ultimately leading to premature activation again of those pancreatic enzymes, causing pancreatitis. So when we go to classify pancreatitis, I'm not big into remembering or memorizing lots of classification schemes, but these are actually, I think some of these things are at least good to know from a knowledge standpoint, and I think have real good clinical implications. Their phases, we think of the early phase of pancreatitis when the inflammatory component is quite high. In terms of types of pancreatitis, there is interstitial pancreatitis, which is the name for sort of your everyday typical pancreatitis. And there's also necrotizing pancreatitis, and these are the patients that actually have dead pancreatic tissue, and we'll explore both of these in a moment. And there's different severities of mild, moderate, and severe. So when we compare interstitial to necrotizing pancreatitis, so interstitial pancreatitis is essentially just inflammation. This comprises about 80 to 90% of acute pancreatitis. 20% of these have more than just mild severity, and this may lead to a pseudocyst. We'll explore all of those terms here in a moment. And about 2% of these patients ultimately die. Necrotizing pancreatitis, on the other hand, this is inflammation with necrosis. Necrosis, again, meaning you have dead pancreatic tissue. This is about 10%, maybe up to 20% of acute pancreatitis cases. Usually, these patients have a more moderate or severe course and may lead to an area of walled-off necrosis. When we talk about pseudocysts and walled-off necrosis, these are basically encapsulations of some of this inflammatory or dead debris. So if it's a pseudocyst, it's an inflammatory ball like a blister, and then if it's walled-off necrosis, you've taken that dead tissue and put it into a ball. And about 20% mortality. So here's an example of an image. So this is a patient with acute pancreatitis. You can see the liver over here, the spleen over here, and here's the splenic vein. And then here's the pancreas. You can still make out some of the gland. The parenchyma is still enhancing, but there's a lot of haziness and a lot of infiltration of the surrounding fat. This is a typical example of acute pancreatitis. And this is a patient with necrotizing pancreatitis. So the gland is actually no longer recognizable here, right? And here you see this layer of pancreatic tissue. And over here, there's actually no visible pancreas whatsoever. This is an IV contrast series, so you're not seeing enhancement of that parenchyma. So that loss of enhancement, or the complete loss of parenchyma entirely, that's pancreatic necrosis. So severity here is quite important. And again, severity here has nothing to do with how much inflammation you see on the CAT scan, and it also has nothing to do with how high those pancreatic enzyme elevations are or the severity of their pain. It says everything to do with organ failure. And it's the organ failure that actually ultimately leads to the high morbidity and mortality of this disease. So we'll define organ failure, and this is according to the recent revised Atlanta classification, of for either hypoxia, hypotension, or kidney dysfunction, creatinine greater than 1.8 or 2. And it's the duration of organ failure that defines your severity here. So patients who have no organ failure, they're mild. It doesn't even matter if you have necrosis or not. If you don't have the organ failure, you're mild. Moderate means you have less than 48 hours of organ failure, so they get admitted, they have a little hypotension in the ER, resolves relatively early. And severe cases have organ failure that persists beyond 2 days. So in terms of mild organ failure, in this one series to sort of evaluate how well this categorization works, about 60% of the patients in this series had mild pancreatitis. There was a 0% mortality, only a few percent in the ICU, and this is your typical length of stay for pancreatitis, an average about 3 days, some up to 5 days. This is the pancreatitis that we all sort of know and see on a regular basis. The moderate cases, now about a quarter of the cases fall into this group. Now you have to a 3% mortality, 22% of them are in the ICU. The length of stay goes up quite a bit to 8, and the 17% of these are necrotizing. And the severe cases, this is about 10 to 15% in this series. Now we're up to 26% mortality. 2/3 of them are in the ICU for some duration, and the length of stay continues to increase, and then now about 37% of these are necrotizing. So if we take a look at the entire spectrum of pancreatitis, and we say about 80% of these patients with pancreatitis have mild pancreatitis, again, no organ failure. Of those, 0 to 1% ultimately end up dying. The rest of these do very, very well. The other 20% have moderate to severe pancreatitis, defined again by organ failure. 2/3 of those have sterile necrosis, and 13% of those die. The other third have infected necrosis, and that's the most feared complication here, and about 25% of these patients die. So obviously deciding what kind of course a patient is going to take is of pretty critical importance. You can see going down which pathway you can really divide out the prognosis for this patient, and also really get a sense of the type of interventions and their hospital course. And so there's a countless number of scoring systems: Apache, Balthazar, TBC, CI, BISAP, Branson's. It's really a veritable alphabet soup, which none of these things make any sense to me, and you're just left screaming for help. And in the end, I don't find many of these scoring systems to be that useful in a clinical scenario. They have some role here when you're doing clinical trials. The one that I think has gained some interest is BISAP because of its ready, easy-to-use formula, and it's just 5 parameters, having a BUN over 25, impaired mental status, and SIRS, age over 60, and pleural effusions. BUN and SIRS we'll explore quite a bit more as we go on, but these are sort of the factors that have been associated with some worse outcomes. None of these scores are great. I think their specificity is pretty good, so patients with low scores tend to do well. But, for the BISAP 0 or 1, 1.6% here with severe pancreatitis and 0% mortality. But again, it is interesting to sort of note some of these things, but I don't think it's mandatory to really think about assessing patients with scoring systems. But keep an eye out on SIRS and BUN. Those factors, I think, are rather important in deciding how to manage our patients. The reason is BUN actually predicts mortality. So this is a retrospective series of, I think, 3 hospitals, I think 5,000 or 6,000 patients with pancreatitis that had serial measurements of hematocrit and BUN. When we go back to the old Ranson's criteria that we all remembered at some point in time, hematocrit was an important part of that, and the thought was hematocrit reflected fluid status. It reflected that fluid sequestration, and then that would be an important factor here. Well, what they did is they took patients and they looked at serial measurements of hemoglobin or hematocrit from admission. And you looked at the patients who survived pancreatitis, and as you'd expect, they came in with a little high hemoglobin or hematocrit, reflecting maybe a little dehydration, and then that their hematocrit decreased over the first 2 days of the hospitalization. But that didn't really differentiate them from the non-survivors. Again, there's a much wider range of numbers here, but those patients too had decreases in their hematocrit over the course of the hospital stay. So by itself, it's not that useful of a distinguishing criterion. But BUN, on the other hand, was rather useful. So if you look at the patients who survived pancreatitis, their BUNs came in, they were admitted a little bit high, reflecting again some volume loss and dehydration, and that decreased over time. And the non-survivors, you'll see that their BUN started up a little high and continue to increase over time. And so this ends up being a much better tool by itself, certainly over using hemoglobin or hematocrit. What if you can combine BUN and hematocrit together? Is that maybe simpler than using some of these scoring systems? And it's certainly easier to remember those two labs to look at. When we take a look at admission hematocrit and kind of divide them into quartiles or quintiles, you'll see that the higher the admission hematocrit, the higher the rates of organ failure and pancreatic necrosis. So the patients in the highest group of hematocrits on admission had the highest rates of failure and necrosis, almost 50%. If you look at the rise in BUN at 24 hours, the higher the rise in BUN, you'll see that the rates of organ failure and pancreatic necrosis continue to rise. Overall, the initial hematocrit over 44% carries an odds ratio of 3, so a threefold increase in rates of organ failure and necrosis. That rise in BUN at 24 hours, any rise at all, not just a certain level of rise, that was associated with an odds ratio of 6, again for predicting organ failure and necrosis. So maybe another way to stratify this, and this is another large series where they looked at just hematocrit and BUN. You take a look at hematocrit that's over 44% on admission, and about a third of those patients had that high hematocrit, and then you look at the rise in BUN at 24 hours. Well, those with the 54% of organ failure. If the BUN didn't go up, the organ failure went down to 16%. And then if you take at the patients who did not have a crit over 44, and it's about 2/3 of them, and then the BUN, if their BUN rose, they also have organ failure of 30%. And if their BUN went down at 24 hours, well, then that organ failure is down to 8%. So fluid status here is really rather important, and you're looking at BUN and hematocrit as surrogates for that fluid status, as well as a measure of end organ functional activities. So let's talk about IV fluids and acute pancreatitis. This has been probably the biggest change in the management of pancreatitis over the last 15 years. We always knew to give them fluids, but it was how much and what type. Why does this even work? So you have acinar cell injury, and from all the things we had talked about, either toxic effect or pressure-related phenomenon from stones, and those enzymes are activated and the acinar cells are injured, and you've got bad pancreatitis. That leads to cytokine release, an inflammatory state that then develops, and now with any inflammatory state, you get local capillary permeability and you get some vasospasm. And then from there, you will then develop some very localized pancreatic hypoperfusion just from those vascular abnormalities at a very small tissue level. That gives you some local level of ischemia, and that of course leads to more cytokine release. Well, those cytokines lead to SIRS, right? So these are the patients that are tachycardic, they're hypotensive, they're febrile, they have their respiratory rate alterations, and their white counts are abnormal. Well, if you get a bad enough state of SIRS and the systemic inflammatory response, that may eventually lead to organ failure. So what if you could break that cycle with enough IV fluids and maintain perfusion? What if you can get rid of that hypoperfusion? You can get rid of that ischemia. Maybe you'd get rid of some SIRS, and maybe you'd get rid of some organ failure. Well, how does the story play out when you look at some of the clinical data? The clinical data is frankly kind of a mess. But some of the series, if you look at ones that are at least a little bit more thoughtful how they approached it, it's a very heterogeneous group, and it's hard to randomize sometimes on such early administration of fluids. But in a retrospective series, they looked at patients who got early resuscitation of IV fluids. And so between the early and late groups, they got the same amount of fluid over those first 3 days of their hospitalization. The question was it shifted more heavily in the first 24 hours? In the early group, you look at patients with SIRS, and 25% of them had SIRS on admission, and that dropped to 10%. And the late group, their SIRS rates were much higher, and they came down much later on in the course. The length of stay was rather different, 11 days down to 8 days, and this, of course, is statistically significant. Is lactated ringers better than normal saline in the resuscitation of pancreatitis? There's been a lot of interest of late, certainly in the pancreatitis world, about using lactated ringers, which better mimics physiology in terms of its neutralizing capacity. Normal saline is actually rather acidic. The surgeons have been using LR for quite a long time. And again, just looking at rates of SIRS alone, if you look at patients in an LR group, high rate of SIRS to start, 30%. And then 24 hours later, that rate of SIRS dropped to only 5%. In the normal saline group, they stayed at about 20%, and these are actually this is a randomized study. And then if you look at levels of CRP, in the LR group, the CRP levels were much lower after getting LR administered compared to the normal saline group, which had a higher level of CRP. So Again, lower rate of SIRS, lower rates of acidosis, and certainly decreased levels of CRP. Here's another study, again, another a very small randomized study, and they were really just looking at inflammatory markers for the most part. And if you look at the saline group, the CRP in the ER was at a baseline, and then at 48 hours and 72 hours, you had the CRPs really rise in the saline group, and in the lactated ringers group, you see that the CRPs are certainly much lower. They went and did an in vitro study, and they actually looked at macrophages. They induced an inflammatory phenotype using interferon gamma and exposed them to LPS. And you can see that normal saline actually increased their the macrophage expression of IL-1B compared to lactated ringers. So just in an in vitro setting, they saw that there was decreased levels in inflammation once you expose them to something like lactated ringers. And they actually showed it's not the ringers part, all of the other electrolytes. If you take out the lactate, the inflammatory component goes up quite a bit. So, small study, no great clinical endpoints in this, but the point is taken that I think using LR, there's at least a decreased inflammatory state, which we think may decrease the rates of poor outcomes. So the pathophysiology of IV fluids helps pancreatitis does seem clear. IV fluids will certainly counter the local microvascular changes in pancreatitis, lead to reduced tissue and systemic acidosis, which leads to lower inflammation. The data is conflicted. There are some studies that show decreased necrosis and mortality. There are other studies that actually show worse outcomes with IV fluids. But some of those worse outcomes might be the fact that patients were doing worse. They had early on some kidney dysfunction and some hypoxia, and then they got flooded with more fluids in an attempt to counteract that, and then they ended up declining. The reason this is all a problem is there's really a lack of high-quality randomized trials. There's a ton of retrospective studies, and they've tried to slice it and control for whatever they possibly can. The limited RCT data is pretty good, but nowadays, since there's been enough interest in pushing more IV fluids, they found that the control group in RCTs are getting a lot of fluids as well, because that's just the way the education has gone in pancreatitis. So it's actually really hard to control and randomize this very well. But that's really, the current AGA guidelines, which came out a few months ago, are really sort of saying that we just need good clinical endpoints in some of these trials to really drive this point home. The evidence suggests improved outcomes with early aggressive IV fluids. This means it has to start in the ER. Once you get to 8, 12, 24 hours later, that inflammatory cascade's already taken off, and now you're chasing yourself. So really 1 to 2 liter bolus in the ER, 200 to 400 mLs of LR for 24 hours reduced to maintenance. If you follow respiratory status, urine output, BUN, and heart rate in sort of a goal-directed approach, at least follow some of these clinical parameters. Now remember, we're not using IV fluids to treat pain. So I have seen patients who are having ongoing pain at day 2, day 3, and then I've seen people turn up the IV fluids. You don't need to do that. The whole point of the IV fluids is you need to counteract that inflammatory cascade. That cascade is on day 1. And so you think of this as trying to counteract that cascade, and then using your parameters to guide your fluid management after that. Nutrition in acute pancreatitis. And this has certainly been an area of much debate, and I think are questions that still come up quite a bit. For the longest time, the thinking and the teaching was NPO and maybe TPN. And the reason why that was out there is that if you eat food, and as you all may be doing right now, as that food gets down in towards your duodenum, you're going to stimulate CCK and secretin. This is going to stimulate bile and also stimulate pancreatic enzymes and bicarb from the pancreas. Obviously, you're making your pancreas work in this regard. Well, then those nutrients get broken down into oligosaccharides and amino acids, goes down to the small intestine, and you get absorption through the small intestine. Well, if you were to make somebody NPO or put them on TPN, or in my cartoon here, put a jejunal feeding tube, so basically nutrients way distal to the pancreas, maybe then you would prevent CCK and secretin, and you would let the pancreas rest. And that may be beneficial in patients with pancreatitis. So there's some pretty interesting science data to sort of support this notion. They took 36 volunteers, which is remarkable to me, and they basically gave them multiple nasal tubes. And I don't know, you couldn't pay me enough to put a nasal tube in to do all the stuff they did here. It's really kind of impressive. They had a tube into the duodenum, and they were able to aspirate the fluid from the duodenum to measure trypsin rates, and that's a measure of pancreatic activity. Then they had another tube, if they were doing enteral feedings, and gave them different types of formulas at different locations to see what the response was from the pancreas. So patients in the fasting state had a low basal rate of trypsin secretion, some right shown here. They were given TPN, again, volunteers, amazing, or paid volunteers. And they had a slight increased rate in their basal trypsin rate. And so now into the duodenum, if you felt a typical 2-feed formula that is sort of polymeric in nature, something like, and with more complex nutrients, you had a really good high stimulation of the pancreas. You're making the pancreas work. If you gave them an elemental formula, things that were already metabolized and broken down, you had lower rates of, and that makes sense because now you're doing more metabolized nutrients. The pancreas may not have to work as hard. But this is what was interesting. They took tubes about 60 centimeters past the ligament of Treitz, and they gave them an elemental formula, and the rates go back to the fasting rate, which is pretty remarkable. And I've seen this anecdotally, patients who've had ongoing pain with pancreatitis, we place a deep jejunal tube and their pain is gone the next day. And it's really a way of really forcing pancreatic rest. And I think some of the theory is the nutrients start to stimulate the ileal brake, and that causes some pancreatic suppression. Anecdotally, I've seen some patients do better with this, but certainly forgetting the fact that you're really suppressing the pancreas, you're certainly reducing it below levels of just eating, and maybe below levels of TPN. Nasojejunal tubes always cause some groans because these can be kind of annoying to do. There have been a lot of different approaches to do this, and I think they've gotten easier over the years. This tube is kind of neat. I don't know if we have it available here. It's a self-advancing nasojejunal tube, or called the tiger tube. If you zoom in on them, it has these little cilia-like flanges on the side of the tube. And this is great. You pass this into the stomach. Every half an hour, you push it 10 centimeters. And the peristalsis grabs these little cilia things, and they drag them down. It's like a 60%, 70% success rate in getting beyond the ligament of Treitz with these tubes. It is fantastic.
We have them.
We do have them? Oh, that's good.
Yeah, nobody uses them.
We should use them more.
Yeah, we have them. Nobody uses them.
These are great tubes, and I mean, where I've worked at places where they actually stopped calling GI altogether for jejunal tubes. Like some surgical services just wanted jejunal tubes, and they just put them in, and they never needed to bother us with them ever again. So these are great tubes to sort of encourage. May not work super well in pancreatitis. It all depends because there's a lot of duodenal edema in pancreatitis, which may prevent this from working. But if in 2/3 of patients overall, they don't need a GI consult or a scope, and whatever to get this down, well, that's fantastic because medical house staff can do this. This is a tube that goes through the scope. This is the one that I tend to use. You go down the scope into the distal duodenum, and you can pass the scope like a savory wire. You throw this way out into the jejunum, and you back the scope out the mouth, again like a savory wire. And there's an exchange to take the tube from the mouth and bring it up out the nose, and that's pretty straightforward. And there's other tubes that go. You can do a transnasal endoscopy, so you can use the pediatric gastroscope, the XP scope, right through the nose. Go right down into the distal duodenum or jejunum, put a wire there, and then pass the tube over the wire. All of these are great modalities, and really there's no reason we shouldn't offer jejunal access to patients who do need them. In terms of nasojejunal feeds versus TPN, 7 randomized trials. In overall mortality, there was a 61% decrease in mortality, 82% decrease in mortality in severe acute pancreatitis, 45% decrease in multi-organ failure, and 61% decrease in systemic infection. The studies clearly demonstrate the superiority of NJ feedings, but you also have to remember you only need to do nutritional support only if the patient's NPO for more than 5 days. They've actually done even randomized studies of starting early, like day 1 or day 2, or starting at day 5. There's no difference in outcome. The body has a fantastic ability to protect itself during starvation, and we should leverage that. In the recent AGA guidelines, they sort of offer sort of various points about the recommendations. And here the recommendation is clear. Enteric feeds over TPN, and they very clearly say no further studies are needed on this topic. They never say that. I mean, it's like this one little line, nothing else needed. Okay, so we consider that solved. Why does this work? Okay, well, in pancreatitis, there was some intestinal dysmotility, partly from all of the abdominal inflammation, and the narcotics they may receive. There is some bacterial overgrowth component to this. And then, of course, with all of that inflammation, you eventually lead to increased gut permeability. All of these things lead to bacterial translocation. So you take the bacteria from the bowel and translocate it into areas of pancreatic necrosis or areas of severe pancreatic inflammation. This process takes time, 7 to 14 days at a minimum, But what enteral nutrition does is it actually improves intestinal motility because you're kind of propagating things through, and then it decreases the bacterial overgrowth. It reverses that gut permeability problem, and overall this decreases your rate of bacterial translocation. So enteral nutrition clearly is superior here. Now the thing that's come up recently is, should you just do a nasogastric tube? And maybe nasogastric feeds are better than nasojejunal feeds. Well, early on, I just got through saying how much better distal jejunal feeds were, or mid-jejunal feeds were at suppressing pancreatic activity. There is some theory, and supported by some animal data, that during pancreatitis, the pancreas isn't really responding to any stimuli anyway. The pancreas is so stunned that CCK and secretin have no bearing on pancreatic activity whatsoever, and that maybe you could just give them NG feeds if they're prolonged NPO for such a while, and they would do just fine. There are 7 small RCTs comparing NG to NJ feeds. No differences in pain, no differences in rates of diarrhea, no differences in feeding intolerance or conversion to TPN. So all of the guidelines, ACG, AGA, IAP/EPA, they all endorse NG feeds as a suitable alternative to NJ feeds. I approach this with a little bit of caution. I think the data for NG feeds is a little soft. Some of the studies actually, instead of jejunal tubes, they did duodenal tubes. And so then we already talked about how duodenal is really not much better than gastric. So I think it certainly doesn't seem to be harmful to patients. Certainly it seems to be reasonably well tolerated. But I tend to believe if you're going to have a patient with sort of longer-term nutritional support, jejunal feedings are going to be better. We just don't have the N yet to sort of demonstrate those differences. But it is worth a shot, all right? In a situation where it's just difficult to place, can't place, or whatever, you could try nasogastric feeds and see how they tolerate. The big thing is to monitor for delayed gastric emptying. All of that inflammation slows the stomach down, the narcotics slow the stomach down, so you might run into a feeding intolerance anyway. This is sort of a comical slide. When we take a look, all of those issues about like nasojejunal feeds or TPN, they all pertain to patients who can't eat for more than 5 days. This slide kind of looks at everybody else, right? There's a lot of interest about that group of patients that can't eat for such a long time. That's a small group of patients. So the question is, how do we feed our pancreatitis patients? When do we start feeding them, and what do you decide? There have been a whole mess of different trials looking at what foods to start with. Do you start them right away in a regular diet? Do you start them on a light or low-fat diet? Do you just use enteral feeds early on? Or something conventional and stepwise, clear liquids and slowly progressing up to like low-fat and full diet? Who decides? Should we let the patient decide? The patient says, I'm hungry, and you say, okay. Or do we let the physicians, the medical team decide? We'll decide when you're ready, and then when you're ready, we'll go ahead and give you feeds. And then, what are you using to decide? Are you using subjective cues? How much pain are they having? Are you using objective cues? Are you going to look at maybe lipase levels or CRP? Or you can look at imaging? Or do you just go on a predefined schedule, wait 1 day, wait 2 days, and then just start and see how it goes? So all of these variables have been looked at in a number of different ways. There's an evolving consensus on this. I certainly have always approached it, wait till the pain is gone, and then clear liquids and slowly progress. I think we're shifting towards a more patient-focused approach. Start the diet early, and when the patient is hungry. When the patient is hungry, it's a good sign that they might be ready to handle food. If they're in a lot of pain, they're not going to try to eat that much. If they're in a lot of pain, there's a lot of inflammation, they're not going to eat to a point to make their pain worse. Patients won't generally do that. So oftentimes they're hungry before the pain is resolved. And so it's worth a shot, and what they've shown in some of these studies is patients won't end up overeating that much. They'll eat a very small amount of their tray, and they'll start to increase their intake as they feel better. Many trials suggest you could skip the clear liquid diet altogether, right? This isn't a food consistency problem, right? This is really an issue of what types of nutrients. So you can skip clear liquid. I would favor going right to low-fat diet. Physiologically, that makes sense to me, but you could go to a regular diet, actually, is what some studies advocate. Certainly, I see no reason for the full liquid diet at all. Cream of whatever just doesn't make sense to me in pancreatitis. Depending on if you're going to give them fat, give them a low-fat diet. And if you're going to go with liquids, just give them a clear diet. But certainly strive to think about when they're hungry, give them a low-fat diet, see how they do. Objective data, labs, CAT scan has no bearing on feeding tolerance whatsoever. At the very least, this approach is non-inferior to the conventional stepwise clear liquids and move your way up. And in fact, there are studies that suggest it's a decreased length of stay. So you may actually knock a day, day and a half off a patient's hospitalization by getting when they're dying a little bit earlier. Antibiotics and pancreatitis. This is another one of those resolved questions, so I'm not going to spend too much time on this. Why are we worried about infection? Well, patients in pancreatitis come in with a high white count. They have fevers, they have tachycardia, and they have hypotension, and everyone freaks out that it's sepsis, and everyone gets put on imipenem because of some horrible studies from 15, 20 years ago. It's not sepsis. This is SIRS, all right? This is a systemic inflammatory response, which we've talked about a few times now. This is a nerve-wracking constellation to have them come in with, and you really are going to be thinking about them being infected. And no different from even maybe your alcoholic hepatitis patients, you also come in with these sort of symptom complex. But this is all just inflammatory response. And so you have to sort of remember that pancreatitis is really a sterile process to begin with. One busy sort of meta-analysis slide here, they looked at prophylactic antibiotics. No effect on mortality, no effect on infected necrosis, no effect on other infections, no effect on rates of surgical infections, and there's some, there's no effect on the rates of fungemia. Some trials show a slight increased risk of this, but it's not really definitive. So when do we need antibiotics? You never need antibiotics in mild acute pancreatitis, period. Recognize SIRS and early acute pancreatitis. This is initially a sterile process. Delayed translocation of gut bacteria to necrosis. This happens 7 to 14 days after onset. So those first 7 days, they are febrile, they're just inflamed. And you need to sort of hold the course unless something tells you otherwise, that they may have a pneumonia or UTI or something else. Remember, prophylactic antibiotics, there is certainly an increased rate of infections with resistant organisms. And that could be a problem, particularly for these patients with necrotizing disease who are in the hospital for 1 or 2 months. And prophylactic antibiotics may be associated with fungemia. Gallstone pancreatitis. So, as you know, gallstone pancreatitis, stones from the gallbladder kind of jump down into the bile duct and get down here towards the ampulla. This sends a brief wave of pressure right up the pancreas, and that causes that premature activation of enzymes and causes pancreatitis. What are the LFT abnormalities in gallstone pancreatitis? This is always a question that comes up. An ALT over 150 is 96% specific, so basically meaning you can be pretty sure if you come in with pancreatitis and a high ALT, it's gallstone pancreatitis. Of course, it's helpful to know that they have stones in their gallbladder. But look at this other patients in this series. 14% had a normal Billy, 11% had a normal ALT, 12% had a normal AST, 26% had a normal alk phos, and 10% had all 4 major LFTs normal. Now, granted, there are some methodological, I can't even say that word today, that there are flaws in that study, but nonetheless, the point is well taken, and that the LFTs don't have to be very dramatic. The kinds of stones that cause gallstone pancreatitis are the tiny ones. This is not the big stone that will get stuck in the mid-bile duct. That's going to cause biliary obstruction and cholangitis. You need to get down to the ampulla and send a wave up of pressure into the pancreas. So those are usually the smallest stones. You rarely catch a stone in the act. They may come in with pancreatitis, and if you get an MRI 3 minutes after it hit the ER, that stone's actually gone. Every so often we'll see one strangler left by the ampulla, but usually you don't. So in the absence of other causes, consider gallstones as an etiology if they do have gallstones in the gallbladder, and if there's any LFT abnormality on admission. If they occur later in admission, that's a different question. Pancreatic edema causes some swelling of bile duct that can cause that. Now the timing of cholecystectomy, this is really a tough one because it's difficult from a hospital resource standpoint. Many surgeons, ideally we'd say, get the gallbladder out on that admission, and many surgeons say, we don't have OR time, or maybe it's going to be too inflamed and it'll make the surgery more complicated, let's do it electively in 30 days. And admittedly, from a hospital standpoint, logistically, it's difficult sometimes to get these cholecystectomies done as an inpatient. But this is a study, they actually randomized patients to getting a cholecystectomy at the end of their pancreatitis hospitalization, or waited 30 days, pretty short interval. And the big endpoint here is there was a 17% rate of either mortality or readmission for gallstone-related complications, be it pancreatitis, cholangitis, CVD stones, or cholecystitis. Compare that to the people who got their choleo of a 5% rate. Those people probably more likely had some post-operative issues that led to an admission. Recurrent pancreatitis, 9% compared to 2%. Cholangitis or CVD stones are relatively similar. In terms of colics, abdominal pains in those 30 days, 51% versus 3%. And I've seen some of these patients in between after they get discharged. They're not very comfortable at home. They are reporting some issues. They're very nervous because they don't know what will tip off the next attack. And they're just kind of biding their time, not really complaining to anyone until they get that gallbladder out. In terms of surgical times, it's the same. So the 60 minutes and 58 minutes in the two groups. So it's not a more difficult surgery, and patients clearly do much better. And I consider this also a resolved question. I do know that it takes a lot to sort of change this pattern, but this is something that really should be addressed. So ERCP and gallstone pancreatitis, there was an old thinking that if you have a stone stuck here in the bile in the ampulla, that we should go in on every pancreatitis patient and pull that stone out to prevent pancreatitis from getting worse. The guidelines recommend ERCP if there's cholangitis, if there's a stone seen on imaging, like somewhere stuck in the bile duct, or if there's ongoing biliary obstruction, so you have progressive bilirubin elevations throughout the hospitalization. We now employ a more conservative approach. If there is a low suspicion of stones, LFTs are gone to normal, they're feeling great. If you want to clear the duct, get an MR. If there is some intermediate suspicion, their pain is persisting, their LFTs are still hovering, we bring them down here and do an endoscopic ultrasound. And if we see a stone there, we go right to ERCP. The reason we'll do that approach is if your pre-test probability is so high, the MRCP is not a great enough test to sort of definitively knock that risk to zero. EUS is a superior test to look for CVD stones. There is no role for routine ERCP and gallstone pancreatitis, and numerous studies have supported this point. So if they come in with gallstone pancreatitis, no reason to go and intervene. That tends to resolve anyway. Anecdotally, it is a more difficult procedure. There's a lot of edema and swelling, and I think you might run a higher risk of getting post-ERCP pancreatitis. And so these are really the only indications to rush into ERCP. The last category to touch on is to look at the management of pancreatic fluid collections and infected necrosis. So this is a pseudocyst. This involves from acute fluid collection. So patients come in with interstitial pancreatitis, they have all this inflammation, and they eventually form a blister, no different from a burn on your hand. It's fully encapsulated, and this is just cyst fluid inside. This is walled-off necrosis. And so this is also fully encapsulated. You can see here, this is very homogeneous, the appearance of these contents. Here you're seeing different echo textures, may not project that well. You see a little area of fat necrosis here. And you're seeing different layering things here to suggest that solid dead debris inside the collection. And so we'll call that walled-off necrosis or a WON. So to intervene on any of these collections, there was an old teaching, greater than 6 centimeters, greater than 6 weeks. Anybody who met those criteria got a surgical procedure where they connected the pseudocyst to the bowel or to the stomach. That is really no longer the case. You really need to intervene based on symptoms. If the patient has an infection of a pseudocyst, they have obstruction, the cyst is big enough to cause the pylorus, the duodenum, or the stomach to get obstructed. They're having recurrent pancreatitis. The pseudocyst might be sitting right on top of the pancreatic duct, causing recurrent episodes. Biliary obstruction, mass effect. Abdominal pain from mass effect of these big collections pushing on adjacent structures. In necrotizing pancreatitis, the reasons to get involved here or to get to intervene here is if you are suspecting or you have documented infected necrosis. I'll show you a couple of CAT scans of this in a moment. There's a notion of persistent unwellness, which is about as vague as it sounds, but they're just kind of smoldering sick for a long period of time. And that might be, you might raise a suspicion, okay, maybe there's a chronic smoldering infection. Persistent organ failure for a long period of time also may suggest you've gotten past the acute SIRS, and now you've got an infection sort of driving that process. So this is from translocation of bacteria. Here's a typical CAT scan that we will see for infected necrosis. This similar CAT scan was actually on my board's exam. I was rather surprised considering that we weren't talking about this that much several years ago. But you can see an air fluid level. This is a well-defined collection. If you see an air fluid level, it's reflecting gas-producing organisms. You can see air trapped inside of here. So imagine like a CT scan of the colon. You see stool and air trapped all around the solid debris. And this even looks more like that. This all looks certainly much more like stool in the colon. You've got all the solid debris and air all around it, and that's basically chunks of dead tissue that's infected. There is a surgical technique. Well, the classic approach is open necrosectomy. Laparotomy, they go into the OR, they retract around all the organs, and they scoop out all of this dead stuff. This was an incredibly morbid procedure. Patients were left with an open abdomen, back and forth to the CQ, back and forth to the OR. They were so swollen and edematous they couldn't close the abdomen on day one. They often had to go back repeatedly. The surgeons are very happy not to do that anymore. It's a rare day that you see them sort of say that, but it is a dreadful operation. The minimally invasive approach is pretty interesting. So what you can do is you can do a percutaneous drain laterally, so you kind of directly enter the retroperitoneum. And then you can actually, from a surgical standpoint, follow that drain in, make a lateral incision, and go along the drain, enter the retroperitoneum, and actually debride them from a lateral incision, and just pull out some of the dead stuff. So there is an incredible group, the Dutch Pancreatitis group. They've done all these incredible, they have multiple multi-center studies across the entire country. You basically call 1-800-pancreatitis, and you get like swooped into this huge algorithm. And so they randomized patients with infected pancreatic necrosis to a step-up approach. So these patients got drains, and drains were enough for 40%, but 60% needed to go to that VARD, that minimally invasive retroperitoneal debridement. A third of patients in the entire series needed more procedures, multiple VARDs, multiple drains. The other group got randomized to open necrosectomy, and they got a primary laparotomy. 42% of those patients needed repeat laparotomies, repeat procedures, repeat drains. In the end, the rates of major complications or death, incredibly high numbers to begin with, right? This is a very morbid disease. 70% in the open group versus 40% in the step-up group, and that was statistically significant. Well, what about the endoscopic approach? We certainly talked about that in our endo conference many times. Here's a patient with a pseudocyst. You can see here we're using a needle puncturing into the cyst. It's a patient with an infected pseudocystic necrosis. We're passing a balloon. We're in the stomach. We've made a connection from the stomach wall right into the cyst. We're going to dilate this tract, and you can see just gobs of pus pouring out. You can imagine how much better this patient felt afterwards. And then we'll eventually place stents there. And then you can actually see that's the hole that goes right into the pseudocyst itself. And so that's pseudocyst drainage and walled-off necrosis. So here's an area of necrosis. You can see the solid debris in with the ultrasound. This is the Axio stent, which we've talked about here many times. It's a metal butterfly stent. It forces the collection to stick to the stomach wall, and now provides a conduit for us to drive our scope into and actually intervene inside the cyst. So in the cyst itself, this is the stent over here. We're dilating up this tract. And as you go inside, you can actually see all this dead tissue all the way throughout. And so then you have to do necrosectomy and actually pull the stuff out. So we're using our typical tools of like rectix, forceps, Rothnets, snares, baskets. These videos, these are, he was kind of filming these videos. It is amazing how hard you have to pull sometimes to get this stuff out. It's kind of impressive. And this is a cast of a dead pancreas, pulled out in one big chunk. And then you go in and look, and you can basically see this is all healthy granulation tissue. I mean, it looks horrible, but there's no dead tissue left in there. And that eventually closes off. And both of these types of procedures, now once you take out the dead stuff or the infected stuff, it just granulates in, right? And then eventually you pull those stents out. So when you look at the data, so this same Dutch group randomized patients, they got the surgical step-up like the previous study. They got a more aggressive drain strategy, up to 3 drains. 50% of them went on to VARD, and then 15% now needed more procedures. So they're getting better at doing this without surgery or without repeated attempts. In the endoscopic step-up group, they got an endoscopic cyst anerostomy, so either a gastrostomy or do a duodenostomy. And endoscopic necrosectomy, that alone was helpful at 43%. 57% went and got debridements. 43% needed repeated procedures, and we know from our experience these patients need multiple necrosectomies. So major complication or death, actually pretty similar in both groups. There's no question that this minimally invasive approach is the right way. Pancreatic fistulas is a huge drop. In the surgical group, they end up with fistulas out that drain site. And so that pancreatic duct, the pancreas will leak pancreatic juices out the drain site in 30% of patients, which can be a real source of morbidity. And it's only 5% in the endoscopic group, largely because you're keeping everything internal. Length of stay, huge difference. 65 days in the surgical group, 35 days in the endoscopic group. Again, an incredibly sick group of patients. So, some final thoughts. Pancreatitis is a common disorder characterized by local inflammation from damage to the pancreas. with associated significant systemic sequelae. Multimodality treatment strategy. Early aggressive IV fluids, preferably LR. Again, the data is not the best, but everything really points towards this early strategy is really the way to go. Early reintroduction of oral diet and mild disease, right? Consider going right to low-fat diet. Enteral feedings and nutritional support is needed. NG, my preference is NJ, but NG is reasonable. Definitely no need for TPN, and you only need support if it's NPO for more than 5 days. No role for empiric antibiotics, period, and discussions, certainly within that first week of care. Same admission cholecystectomy and gallstone pancreatitis, certainly don't need a routine ERCP, but in selected patients we know they do need them for persistent biliary obstruction. Pancreatic necrosis really requires a multidisciplinary approach. We work closely with our surgeons, with our IR colleagues, and we often start with really preferably a percutaneous approach or an endoscopic approach. The era of going right to open necrosectomy as a de facto way to do things is really no longer. Every patient's very different, and so it is hard to study that group of patients, and we really work as a team to figure out the best strategy.